The third case is from Sree Chitra.
Yes, sir.
Trivandrum, and you please, one of you please, who the presenter may please tell his name and introduce others and start the case.
Sir, myself, Dr. Anil Kumar, sir, a cardiology resident from Sree Chitra Tirunal Institute of Medical Sciences from Trivandrum. And my colleagues are Dr. Harsh Pandey and Dr. Rohit.
Fine, you start sharing your screen and go ahead with the presentation.
Good afternoon, sir.
Good afternoon.
Yes. Yeah.
Anil, your name is Anil, no?
Yes, sir.
Okay, go ahead.
I am presenting a 48-year-old lady. She is housewife, resident of Alapla, present to our institute with chief complaints of breathlessness and swelling over legs for last 4 years and abdominal swelling for last 1 year. Coming to the history of present illness, she was apparently all right till last 4 years. Then she developed breathlessness and exhaustion, which was insidious in onset, used to occur initially on carrying heavy grocery bags and climbing more than 2 flights of stairs, and has gradually progressed over a period of time to the extent that she feels breathless even after doing her daily routine activities like bathing and going to washroom for the last 1 year. That indicates like she progressed over last 4 years from function class 1 to function class 3 for last 1 year. And no history of paroxysmal nocturnal dyspnea and orthopnea. And she also says that there is breathlessness is not associated with the fever, cough, or expectoration, and there was no seasonal or diurnal variation, and that is relieved by taking rest. Along with dyspnea, she also complained of fatigue that gradually progressed from function class 1 to 2. And she also developed swelling of both the legs for last 4 years, and initially which is confined to both ankles and has gradually progressed up to mid-thigh level for last 1 year. And swelling is usually more prominent on prolonged standing and at the end of the day and tends to decrease on lying down and not associated with pain, discoloration, facial puffiness, or decreased urine output or hematuria or frothing of the urine. And for the past 1 year, she also noticed abdominal distension, which is associated with the feeling of abdominal fullness and early satiety, which is increasing in onset, gradually progressive, and hampering her daily routine activities, requiring fluid removal 5 times in the last 6 months, which is not associated with altered bowel habits, vomiting, jaundice, or hematemesis, or malign or altered sensorium. And there is no history of chest pain, palpitation, or syncope, and no history of cough or hemoptysis, and there is no history of prolonged fever with skin lesions or joint pains, no history of recurrent LRTI, heart failure, hospitalization, or cyanosis, no history of hot flushes, loose motions, or abdominal pain, or noisy breathing. No history of limb weakness or slurring of the speech. Coming to the past history, she has no history of similar complaints in the past, and she is not a known diabetic, hypertensive, or coronary artery disease, or renal disease, or no liver disease before. No history of tuberculosis or obstructive pulmonary disease. No history of rheumatic fever. Treatment history: she is incidentally detected to have heart disease in 2012 on routine evaluation for her routine workup for renal calculi. And she was started on tablet warfarin since then, and she is taking diuretic. She says like she was taking medication which increases her urine output every day. So for last 1 year, she is taking that medication. And family history, there are no similar complaints in the family. And personal history: she attained menopause at 55 years of age and taking mixed diet, a normal bowel habits, a normal sleep pattern, and she is mother of 2 children. Last childbirth was 17 years back. To summarize, 48 years old lady, resident of Alapla, present with gradually progressive dyspnea and exhaustion from function class 1 to function class 3 over a period of 4 years, with pedal element abdominal distension, without history of orthopnea, paroxysmal nocturnal dyspnea, chest pain, palpitations, or syncope. History is suggestive of right heart disease. So from the history, we are considering one is differential diagnosis. One could be pulmonary hypertension, as she is a female with history of oral anticoagulation intake and onset of dyspnea and features of right heart failure. And there is a second possibility we are still considering constrictive pericarditis. And other possibilities could be RV cardiomyopathy, likely could be ARVD, rhythmogenic right ventricular dysplasia, or endomyocardial fibrosis. And fourth one could be organic tricuspid valve disease, probably secondary to rheumatic heart disease or carcinoid or Epstein's anomaly. And fifth, if she is a 48-year-old, still there is a possibility of coronary artery disease with RV ischemic disease, leading to RV dysfunction and right heart disease.
We have put pulmonary hypertension, chronic thromboembolic as the first possibility. He also gave a history of oral okay. Why did he bring that as the first differential diagnosis?
Sir, history-wise, she is a female with onset of symptoms with dyspnea with
Any syncope?
syncope history is not there, sir.
Any low output symptoms otherwise?
She had fatigue, sir.
Symptoms?
She had fatigue.
Are you impressed with that? Why first diagnosis? That I'm telling you, RV cardiomyopathy is my first diagnosis. Why are you putting pulmonary hypertension as the first diagnosis?
So,
What chronic thromboembolic, that too, because of the swelling because of swelling of legs, or
yes, sir.
Dr. Anil, are you carried away by the history? This patient was taking warfarin.
Sir,
Like you did mention in the history that this patient was also taking warfarin, right?
so that is why you are thinking about. Oh, that's a good question.
Yeah. No, another thing, Anil, see, this history is spread over nearly so many years, right?
sir, actually, she was symptomatic for last 4 years, sir, but she noted to have heart disease for last 9 years.
How often a patient of chronic thromboembolic pulmonary hypertension presents with ascites and pedal edema, repeated, peritoneal aspirations? So how often you see? Only our debate here, our concern is, why did you put pulmonary hypertension as the first differential diagnosis?
Order of diagnosis is what I'm asking. Yeah.
So congestive pericarditis, okay, or even RV cardiomyopathy, the two coming from Kerala, it should have been the first differential diagnosis.
Yes, sir.
Then you also said organic tricuspid valve disease. You're thinking of carcinoid, something like that?
Yes, sir. I have mentioned like a rheumatic or carcinoid or Epstein's also.
Yeah, still it could be rheumatic that we have seen, mitral valve disease with severe organic TV disease. So, no, why did you put pulmonary hypertension as the first diagnosis? That is the only question. Otherwise, all other things, second, third, and fourth, you were okay with that.
Sir, like she was telling, like she noted to have symptoms, both the dyspnea and the pedal edema together, and she has taken history of warfarin anticoagulation also. So it could be possible.
Taking history of warfarin, but do you know that she might be in atrial fibrillation for all you know, no? Why she has to have thromboembolic pH to be on warfarin? From history, can you differentiate that a patient is in atrial fibrillation? Chronic atrial fibrillation. This patient, I'm telling you, is in chronic atrial fibrillation.
But no history of palpitation, sir.
Do all atrial fibrillation patients give history of palpitation? Chronic atrial fibrillation?
May not, sir.
Yeah.
Which group of people do not? The younger or the older?
Older patients.
Atrial fibrillation, don't give history of palpitation. Which group of them? Which age group?
Usually older patients, sir. They may not come.
Because our dyspnea progress from class 1 to class 3 or 4 years.
Yes, sir.
That is very unlikely for a severe pulmonary hypertension patient. I think we'll move on. Okay.
Okay, next. Let us go for the examination.
Carcinoid affect left heart?
Yes, sir.
Sorry,
Can affect, sir. Yes, sir.
So which carcinoid can affect left heart?
Lung carcinoid, or in patients with liver carcinoid with a presence of AST, or with very high levels of serotonin levels also. It's possible.
Okay, fine.
She is conscious, coherent, and cooperative, moderately built and nourished. Centimeters and weight is 50 kilograms. BMI is 20.8 kilograms per meter square, and Opsman is 149 centimeter. And she looks pale. There is no icterus, cyanosis, clubbing, or lymphadenopathy. There is evidence of bilateral pitting pedal edema, and bilateral varicose veins are present. Oral cavity examination was normal, and no thyromegaly. Spine and fundus are normal. Vitals, temperature is 98.2 degrees Fahrenheit, pulse is 66 beats per minute, which is irregular, variable in volume, normal character, no radial or radiofemoral delay, normal condition of the vessel wall, all peripheral pulses were felt. And apex pulse deficit is around 9 beats per minute. And BP in right upper limb is 120 by 80 millimeters of mercury, left upper limb is 120 by 82 millimeters of mercury, left lower limb 134 by 84 millimeters of mercury, and right lower limb is 132 by 80 millimeters of mercury. And respiratory is around 16 beats per minute, abdominal thoracic, and saturation 98% at room air.
Why did you take all the full limbs pressure?
Sir?
Why did you take all the full limbs pressure? All the full limbs, lower 2 limbs, upper 2 limbs.
On 4 limbs taken. To rule out any embolism evidence.
Okay, carry on.
Coming to CVS examination, JVP is elevated, which is intracranial, and AVV is absent. There is prominent V wave and sharp Y descent. And in inspection and palpation, chest is bilaterally symmetrical, trachea is central, and apex beat is present at 15 intercostal space, 2.5 centimeters lateral to mid-clavicular line, which is localized and normal LV type. There is no left parasternal heave, no suprasternal pulsation. There is systolic hepatic pulsations are felt. There are no scars or sinuses. On percussion, liver dullness was present at right midclavicular line in 15 intercostal space, and right heart border present 5 centimeters lateral to the right of the sternum, suggestive of right atrial enlargement, and left heart border percussion revealed dull note lateral to the apex beat, and left second intercostal space is resonant. On auscultation, first heart sound is variable in intensity, and the second heart sound is a aortic component is greater than pulmonary component, and pulmonary component is normal in intensity. It's normally split and normal respiratory variation. There is evidence of RV, right ventricular third heart sound, no evidence of fourth heart sound. There is no evidence of opening snap, ejection click, pericardial rub, or pericardial knock. There is evidence of 2 by 6 pansystolic murmur at left lower sternal border, which is medium pitched, blowing in character, best heard with the diaphragm of stethoscope in supine position, intensity increase with inspiration and on leg rising. So other system examination, GIT, it revealed there is hepatomegaly with the liver span, which is non-tender, and there is evidence of tensitis, where there is evidence of fluid thrill present. On RS examination, there is decreased breath sound in bilateral infraxillary area, but there are no crepitations or V's. On CNS examination, there is no focal neurological deficit was present. So to summarize, sir, the 48-year-old lady with history of dyspnea and exertion and pedal edema for last 4 years and ascites for last 1 year with no history of PND or orthopnea. And an examination noted to have anemia with irregular pulse, and the JVP showed elevated absent A wave with prominent V wave and rapid and sharp Y descent with systolic hepatic pulsation, and the 2 by 6 pansystolic murmur left lower sternal border, suggestive of moderate to severe TR, and there is evidence of cardiomegaly with the secondary to right atrial enlargement, and there is disc pressure between the left heart border and apex, may indicate there is evidence of pericardial effusion, and P2 is intensity is normal, ruling out pulmonary hypertension, and RVS3 is present, suggestive of RV dysfunction, and there is no pericardial knock. So from this history and examination.
No, Dr. Anil, I did not take 1 second. What is the murmur? Did you hear a murmur?
Yes, sir. Pansystolic murmur of 2 by 6 intensity, sir. Great.
2 by 6, huh? Okay.
So to summarize, we suspect right heart disease, which probably is related to the RV cardiomyopathy, or secondary to organic tricuspid disease, or third possibility still constitutive pericarditis with severe tricuspid regurgitation with RV dysfunction in right heart failure, with no evidence of pulmonary hypertension, and AF with the controlled ventricular rate in functional class 3. And there is evidence of pericardial effusion with no evidence of tamponade, and no evidence of infected endocarditis and acute rheumatic fever. And she also did have anemia and massive ascites.
You had Carvalho's sign was positive, right?
Yes, sir.
How often you get Carvalho's sign with RV dysfunction?
That actually, but it's there, sir. That actually going against complaint RV.
Was there any pericardial knock or anything? Nothing.
Sir, no. Sir.
So now with this finding, you tell us whether it is it goes with constrictive pericarditis or with RV cardiomyopathy.
What kind of RV cardiomyopathy?
sir.
You're
Sir.
talking about EMF or?
Yes, sir. Probably EMF.
Yeah. So why this is not biventricular EMF? Why are you calling it RV? How does biventricular EMF present?
But actually here, sir, there is no evidence of LV involvement, sir, as of
No. How do you?
no.
What way? What are the things that tell you there is no LV involvement?
Sir, here there is a very huge ARIA dilatation, and there is evidence of
Biventricular EMF, in other words, does it present? How does it present? You get left heart symptoms at all? Or this could be the same thing and yet you could have biventricular EMF, right? It's present just like RV EMF is what you are the ones who should be telling us. We don't see as much. Kerala sees it all, right?
Is the presence of severe RV EMF right heart failure? How do you really find clinically the evidence of LV involvement? That's what sir is asking.
Very difficult, to make out any LV involvement. You don't necessarily, even history-wise, you may not get it, no?
So there is no evidence of LVS3, no evidence of MR, and no evidence of any LV dilatation also. So probably we felt like there is no evidence of LV involvement.
Okay.
History was there, right? Dyspnea on exertion.
There is no history of paroxysmal nocturnal dyspnea, but still this history of
You
dyspnea.
get paroxysmal nocturnal dyspnea. You not get. That's what I'm trying to tell you. You have to always entertain. That's what we were at least talking about. After that, we have not seen any EMFs of late. Yeah.
You can say that RV EMF with predominant RV involvement.
That's what you should say. Yeah.
So shall we move on to the investigation?
Was there?
Yes. How much time are we? Can we have a interim? People should keep telling us the times. Yes. Suddenly, 5 minutes before, if we come to know the time, things become a little difficult. No. What?
Okay, I will tell you well in advance. Go ahead. Go ahead.
It is in RVEMF. You said there is a pansystolic murmur, no, grade 2.
Yes, sir.
So in RVEMF, the TR can be torrential, but murmur grade may be less. Why?
So usually it's low pressure tears, sir.
It's almost like a conduit.
Like there will be a continuous flow from RA to the PA usually in RVEMF. So we may not get a high intensity murmur.
See, does this murmur rule out constrictive pericarditis?
It's a constrictive pericarditis. Usually you won't get TR murmur. There will be involvement of AVL involvement.
You're absolutely correct. Suppose if you're thinking of a constrictive or restrictive physiology, if you are hearing a very good murmur, systolic murmur, so it, very, very unlikely, it almost virtually rules out constrictive pericarditis. So what murmur, if at all, if you can get in constrictive pericarditis? Rarely.
Murmur. Initial stage,
if it is confined to the AV groove, constriction, if it's confined to AV groove.
Sir, MDM murmur we can get. It behaves like MS.
Yeah, rarely. Kussmaul sign did you mention? Because we could not appreciate that.
That is intracranial, sir, JVP, so we couldn't able to elicit.
Suppose if JVP is intracranial, is there any other way of assessing the jugular venous pressure?
Sir, we have to ask the patient to sit with the legs dangling down, and otherwise, if still we are not able to see the upper word of the JVP, we need to ask him to stand and examine.
How does standing and exam going to help and bring out an intracranial JVP from sitting and standing? Is RA pressure going to come down?
No, sir. Actually, IV means like a venous return will come down, sir. Somehow, some pressure over the RA may come down.
Is there any other way? Any other method?
Or otherwise, compression of the abdomen to. No, sir.
What is Wertner's method?
Sir?
Not heard of that. It's okay.
Your pulse is irregular. Your the pulse is irregular. Could it be due to other reasons other than atrial fibrillation? This type of facility.
Sir, pulse is irregular. Not audible.
How do the pulsus paradoxus create?
This paradoxus is not there, sir. Actually, we didn't mention that, but it's a pulsus paradoxus by BP. We found it around 8.
Sometimes pulsus paradoxus can look like atrial fibrillation because of this variability in the.
Sir, your voice is breaking, sir. Not clear, actually.
Okay, carry on.
So,
So the investigation.
So ECG, 12 lead ECG with a normal standardization showing no evidence of PVF, just of atrial fibrillation with ventricular rate around 70 beats per minute. With QRS axis is around plus 60, and with evidence of T wave inversions in V1 and V2. Overall suggest of AF with the control ventricular rate, sir. With no evidence of PAH actually.
There any QRS alternance? Why do you see some variations in the QRS morphology in the precordial leads?
It could be aberrant bits, sir, probably.
You didn't fix the leads properly, is it?
No, sir, it could be.
How do you identify atrial enlargement in the presence of atrial fibrillation?
QR pattern in V1.
Will help to identify.
And yes, sir. Actually, usually in EMF it is described like QR pattern in V1 and early transition. Usually it indicates.
Indicates what?
Indicates RA enlargement. QR pattern in V1 suggests of RA enlargement, sir. Sure.
How can you identify LA enlargement in ECG with atrial fibrillation?
With evidence of LVH, sir.
LVH.
And course.
All atrial enlargement, LA enlargement will have LVH? Or the other way?
Course.
Okay. Go ahead.
Chest X-ray, PA view showing CTR ratio of around 0.8 with large, hugely dilated RA and this prominent SVC shadow, and there is aortic and PA shadows appears normal. There is no left atrial enlargement. This coronary angle seems to be normal.
Go back.
Yes, hold on.
Go back.
So, chest X-ray PA view showing cardiomegaly with CTR ratio of around 0.8 and with the dilated RA and prominent SVC shadow, and aortic knuckle and MPA shadow looks normal, and there is no evidence of LA enlargement.
Why it is not a pure pericardial effusion?
Cardinal angle looks normal, sir. And
How is
pericard.
the venous markings? Are they seen well or not seen well?
No evidence.
Why it is not a pericardial effusion?
Yes, sir. Because a sharp cardiac borders are seen, still possibility that there is evidence of pericardial effusion.
What is the shadow behind the just below? As you trace this, can you trace the SVC shadow from above down? Yeah, what is that part?
SVC.
The lower widened part is also SVC widened like that. Where is the upper end of RA normally?
Okay.
Which vertebral level?
Upper end of RA it will be around
SPC junction. Which vertebral level?
Around 5th vertebral.
What are the cardiac events seen at T4 vertebrae? Cardiac anatomical structures at T4.
One is tracheal bifurcation will happen, sir. And
Okay, you can go to the echo.
sir, a subcostal view showing dilated IVC with less than 50% collapse, and dilated hepatic veins also noted, and there is IVC is turning into right sided atrium. And the subcostal view showing SVC is draining into RA, and RA is hugely dilated, and there is intact atrial septum. And apical four-chamber view showing RA, hugely dilated RA, and there is tricuspid wall leaflets are seen, and RV cavity looks very small. That's RV cavity is obliterated, and dilated RA, dilated and aneurysmal RA pushing that LA towards the left, and this almost LV is encasing this RV, and there is a moderate to severe TR on color Doppler.
And there is no LV involvement at all, or apex of the LV?
So apex of LV is
Spared.
not obliterated.
Very good.
And parasternal long axis view showing
Where is the septal leaflet of tricuspid valve?
There, sir. There is no septal plastering.
Okay.
Sir. And there is a difference between this mitral wall and tricuspidal attachment also very less.
No, you're not showing RV cavity. It's all filled up, or there has to be some RV cavity. Okay, we'll see RV OT. Yeah, we'll see RV OT. Okay.
Yes, sir. So, sir, parasternal long axis view showing there is mild to moderate pericardial effusion, and LV contractility is looking good, and there's mitral wall and tricuspid wall are seen at the same level. And this is a parasternal short axis view showing dilated RA, and this RVOT is seen, sir, and there is free flow of blood from RA to PA, and there is evidence of severe tricuspid regurgitation. And there is
septal leaflet is seen here.
Sir?
Septal leaflet. The tricuspid septal leaflet is seen, although it is
yes, sir.
It's attached a little. What about ATL?
ATL is freely mobile. Sir.
Yes.
Yes, sir. Sir, color M mode at the level of pulmonary valve showing there is evidence of mild tricuspid regurgitation, and followed by there is pre-systolic flow into the PA. Pre-systolic forward flow into the PA. Characteristic of RV EMH, sir. This M mode showing both mitral wall leaflets and tricuspid leaflet at the same level. MCT. So cardiac MRI showing fourth chamber view showing a hugely dilated RA.
Next is
and
perhaps SCV, na?
Sir?
They are there.
Sir?
Go ahead, go ahead.
Yes, sir. Cardiac MRI, 4-chamber view showing a hugely dilated RA, and this oblated, very small RV is seen with the apical obliteration, and there is LV is encasing RV cavity, and there is evidence of a significant MIS severe TR, and the septal leaflets and mitral leaflets attachments are seen, and the septal leaflet is not plastered to the septum.
What else is seen?
Now, why do you say this is not Epstein?
So there is no apical displacement of tricuspid leaflet, significant apical displacement of tricuspid leaflet, and septal leaflet is not plastered to the septum, and there is no evidence of ASD.
A third, yeah.
Okay.
So this outflow view showing SVC to SVC and IVC draining into the RA, and there is RV outflow is seen, and RV apical obliteration is clearly demonstrated.
Yeah, that is the one that otherwise in apical 4-chamber you will get always confused whether it is Epstein or this thing. This particular
Sir?
I think you're muted, sir. Are you speaking? You're muted, sir.
Okay. So particularly in an in an apical 4-chamber, it gives an, I mean, if somebody asks you whether it could be Epstein, you will be in a confusion. That sort of a picture we saw. So this is actually very typical of RVMF, what images you are showing. Because RVOT is dilated and apex is obliterated. This apical obliteration you don't get in in Epstein. The RV apical obliteration you don't get in Epstein.
These are excellent images here. It
Yeah.
is worth publishing. I don't think I haven't seen an Epstein, RVEM of this kind in ages. Do you get to see all? This is
No, we also probably, what is
Here
Sree
also-
Chitra's experience? Very less.
These pictures are fantastic. Yeah, superb.
Because it's a low pressure TR, the MR images are better than echo images.
Exactly.
Yeah. Okay, fine. So this is the this is one differentiate between Epstein versus your RVMF. Apical obliteration is typical of RVMF.
Sir, it's a delayed galvanium enhancement. It's seen subendocardial level, sir. The suggest of RVM, subendocardial enhancement with apical obliteration. Delayed galvanium enhancement.
Okay.
So,
Anything good you can do for this patient?
sir, currently patient was in having massive ascites with right heart failure symptoms. Now currently we are stabilizing her with medication, sir. Later on, we can consider for RV endocardiectomy with tricuspidal repair. But here the RV cavity is very less, so we can offer her BDG also. BDG also one possible option for her.
What was the procedure earlier? It was done for RVMF.
RV endocardiectomy with the tricuspidal repair, sir.
They used to call what is called RV coring. RV coring.
Stripping of the.
Yeah, but anyway, the outcome is not very good even with that because there is no functioning RV.
Mortality is around 30%, sir.
Yes.
Do these patients become candidates for transplant at some point in time?
Sir.
Have you all ever done those or?
No, sir. But there is no evidence of PAH. Still, they're candidates for transplant.
Yeah. So one good point in the chat box, somebody has mentioned about with an LVEMF associated, generally you look for signs of pulmonary hypertension, which were not there in your patient. That is one pointer that should have been pointed out.
The other thing, Dr. Anil, you said PA pressure is normal. So in fact, a surgeon feel heart-lung transplantation is easier than, single transplantation. It is.
Yes, sir.
if at all, I mean, of course, this patient, that's what many transplant surgeons have expressed. Both heart and lung transplantation is much easier than lung transplant. Of course, that is for PPH. Okay. The only thing is, we were only initially, when you put the differential diagnosis of thromboembolic pulmonary hypertension, that was not going with these findings. So your RV EMF or RV cardiomyopathy should have been your first diagnosis. That is the reason many times nowadays these medications are given for more than one reasons. So warfarin, as Praful was telling, it could be atrial fibrillation. That's what it is.
I suppose you did it out of the fact that you're presenting in an exam and shouldn't give the correct diagnosis first. Is that what it is? Why did you bring in thromboembolic PH at all as the first diagnosis?
Because she is taking warfarin and
Okay.
That is commoner is atrial fibrillation ke liye warfarin when you are suspecting this thing. What about constrictive pericarditis and atrial fibrillation occurrence?
10%, sir.
Yeah, so there is a Dr. Wise series is there, no? Dr. P.L. Wise series is there of constrictive pericarditis.
More. Particularly with the age, it becomes more. Maybe after the age of 50, 45, it is almost 1/3. You'll have atrial fibrillation, constrictive pericarditis. Okay.
Do they do bidirectional Glenn at your place for these kind of EMF? They're doing BD Glenn?
No. Sir, usually, ma'am, yeah, you need a bidirectional Glenn will be done, but till now it was not done.
So that is what is planned, and they'll, I mean, they'll do something to the RA, placate the RA, or
RV plication.
atrium? Just bidirectional Glenn without.
Do they reduce the size of the RA?
RA size will be reduced. RA plication.
Yeah, that's what it is. RA reduction.
A reduction.
I think we are done with that, isn't it?
Yeah.
Okay.
I think it's a fantastic case. After
Yeah,
a
very
long
good
time
presentation.
seeing a case of
RVEMF.
EMF, that too purely RVEMF. We often used to say a mixed picture, but pure RVEMF, after a very long time, we are seeing a case. Fantastic.
Yes, again, for the previous case, somebody's asked what are the results of balloon aortic valvuloplasty for RHD. So we haven't published any data as such, but I remember there was some series from Sree Chitra where both mitral plus aortic plus only aortic for rheumatic heart disease, and up to a 5-year outcome was good for these patients. I mean, I don't exactly often remember, but here they have asked, somebody's asked some of the students.
Yeah, I saw in the chat box. Thank you.
So,
Thank
but
you for answering that.
Behaves differently, not like our adult aortic stenosis. That you should keep in mind. The aim is just to postpone surgery in the younger population that is afflicted with rheumatic heart disease, and it is very possible in this patient, especially the aortic valve was good to do also, provided like what we were not able to exactly figure out where the mitral commissures were, but we used to do them in the good old days. Nowadays, we hardly get such kind of isolated AS and MS cases at our center.
Even now, double valve replacement mortality has come down. Actually, what used to be around 10%, now it is definitely less.
Yes, but all rheumatic heart disease, as much as you can postpone surgery, that's another. Surgery is another disease that one must keep in mind. A valve replacement is a disease all your life. With warfarin taking for our population, it's huge. We never see what tip of the iceberg cases that we see with choked valves. There are so many elsewhere. Who has follow-up? Which surgeons have follow-up of double valve replacement long-term? What's happening to them?
So we have 270 cases of prosthetic valve thrombosis in our registry, which is ongoing.
Absolutely. So that
is a real
huge
problem.
So as far as possible, delay surgery. That's what the message I was trying to give.
Okay, thank you very much.